All right. Hi, good afternoon. This is Todd Dardis at the University of Washington, and this is the Northwest Heart Failure Collaborative. Welcome, everybody. I just want to remind people to mute your microphone if you're not speaking, so that we don't have any extra sound for people who are speaking. Please silence your phones or pagers, other audio notifications that you may have. Close doors and otherwise try to keep a quiet environment where you are. If you do have multiple people in the room, remember that at the end of the discussion here, you'll need to email nwhfc@uw.org with all of the names of your participants if they want CME credit. And please go ahead and log on with your phone or other web browser to rwpoll.com using the session ID UW-ECHO, which will allow you to answer our questions, and so we can see what the knowledge base is of the audience and address those issues during the talk. We have today Dr. Jordan Prutkin. Who's an electrophysiologist here at the University of Washington, presenting on atrial fibrillation and heart failure. And Peg Hanrahan from Harborview will be presenting our case. So I'll just take a moment and let the other members of the panel introduce themselves, starting with Jennifer.
Hi, I'm Jennifer Beckman. I'm a nurse practitioner here at University of Washington with the heart failure team.
Jordan's already been introduced.
I'm Alice, and I'm the social worker here with the advanced heart failure team.
My name's Andrea Mira. I'm one of the pharmacists that works with the heart failure and cardiology group here at University of Washington Medical Center.
All right. So we get our questions up there, Randy, in the presentation.
It's next to advance. Yeah.
Yeah. Okay. This is Dr. Prutkin's disclosures. And learning objectives today are to assess the impact of atrial fibrillation on heart failure with reduced ejection fraction, apply appropriate anticoagulation management, and identify when to use rate and rhythm management options. So please do go to rwpoll.com and log in using the session ID UW-ECHO, and you should be able to put a response to our question here. And question 1 is, strokes in patients with atrial fibrillation only happen during atrial fibrillation episodes. Is that A, true, or B, false? Give people one more moment there. So strokes in patients with atrial fibrillation only happen during atrial fibrillation episodes, true or false? All right. 100% say false. All right. Question 2. Which drug should not be used in atrial fibrillation with New York Heart Association Class 2 heart failure with reduced ejection fraction? So which of these is not compatible with that New York Heart Association with reduced ejection fraction? A, amiodarone, B, dofetilide, C, dronedarone, or D, sotalol? Go ahead and enter a response there. All right. So 25% for dofetilide and 75% for dronedarone. All right. And rhythm control is better than rate control in atrial fibrillation with heart failure with reduced ejection fraction. Either A, true, or B, false. Rhythm control is better. True or false? Somehow we're not advancing here. Come on. There we go. All right, so we have a 50-50 split on that one. Excellent. So I'll just hand it over to Jordan now. Jordan, I don't know if you mind just saying what your clinical practice is like here and what your interests are before you get rolling here.
Sure. So first off, thank you to the Northwest Heart Failure Collaborative for having me here today. So I'm Jordan Prutkin. I'm the medical director of our EP lab here at UW. I'm one of the electrophysiologists. Been here for about 7 or 8 years now. And I see the gamut of patients, see a lot of AFib. We, of course, at UW see a lot of heart failure, so I see a lot of AFib in heart failure. But one of my main interests is sports cardiology and sort of looking at athletes across the spectrum from young to old with various rhythm issues.
Great.
Just great. Yeah. Okay. So just a little background on AFib. I think you guys know this already, but that AFib is really a disease of aging, and there's a pretty increased prevalence as you get older over time. Have the mouse here, and that by the time you get to age of 80, about 10% of people in the United States have atrial fibrillation. This paper and data is a few years old at this point, but the projections seem to be looking something like this. What we're seeing is that over time, we're going to see significantly increased numbers of patients who have atrial fibrillation. Part of that has to do just with aging demographics, and you have the baby boomers who are going to be getting older. And so we'll just see increased numbers based on that, but also increased prevalence of some of the comorbidities that are associated with atrial fibrillation, diabetes, hypertension, sleep apnea, things like that. So this is really something that we're going to continue to see a lot of over time, and again, especially in patients who have heart failure. And one of the things that I think has been changing over the last few years and really has changed my thought process a lot as I think about atrial fibrillation has to do with the fact that this is not just a disease of stasis because the atria aren't contracting. Traditionally, when we think about AFib and we think about clots that are associated with AFib that can lead to stroke, it was this idea of, well, in atrial fibrillation, the atria are not contracting fully, and therefore you get stasis of blood and you can get a clot that forms. But there's been a lot of data that comes out that says that that is really just a small part of this, and that there's issues with endothelial dysfunction, with increased inflammation, and with it just changes in the atrial tissue itself that can promote thrombi. So when you look at patients who have atrial fibrillation, there's elevated levels of interleukin-6 and von Willebrand's factor, which are associated with inflammation. These can affect increased levels of some of the prothrombotic factors, D-dimer, prothrombin. And so part of these factors can increase your risk of having a clot in the setting of atrial fibrillation. At the same time that these factors can influence the endothelium of the left atrium, so you have an increased rate of endothelial dysfunction in the left atrium itself. Part of that is also influenced by changes in the extracellular matrix, changes in fibroblasts, changes in properties of the atrial tissue. There seems to be increased levels of platelet activation in people who have atrial fibrillation. And then you have areas like this with the left atrial appendage where you have areas that can promote thrombi. But one of the things is that all of these factors in and of themselves mean that you can have thrombi that form in the left atrium that either aren't associated with the left atrial appendage or that are occurring when you get into normal sinus rhythm. So what I mean by that, there we go. So this were 2 studies looking at patients who had pacemakers, looking at when they had atrial fibrillation and looking at when they had a stroke. So these are, it's a little bit complicated, these slides, I'll try and, or this slide, I'll try and take you through it. The line here in the center is when a patient had a stroke. So both of these studies, trends and asserts. The gray is when someone was actually being monitored. So when they had a pacemaker in place that could look for when they were having atrial fibrillation. So this person had a pacemaker here in the upper line of this whole box. And then the black is when they were having atrial fibrillation. And what you can see here, just for example, this first patient is the last time that they had an atrial fibrillation episode prior to their stroke was about 20 months before their stroke event. Similarly, this patient here was about 16 months. This one was about 6 months or so. And so you see here, again, this group of 3 patients had a stroke, had a history of atrial fibrillation, but they were not in atrial fibrillation when they had their stroke. Now, some patients, like this one here, were in atrial fibrillation the whole time. And you can sort of see a smattering from this study and similarly with this study. But I think one of the things that has really changed my paradigm as I thought about these patients is that AFib is associated with stroke, but it's not necessarily causal in all patients. And some of the strategies that people have used in the past of saying the only time that you need to anticoagulate patients who have AFib is when they're actually in AFib, that strategy has never panned out, and it's probably related to these factors that you can get clots that form in the left atrium that have nothing to do with the AFib episode. Now, it's probably also due to the fact that people who get AFib can have strokes for reasons that have nothing to do with AFib. It might be due to carotid stenosis. It might be due to LV thrombi in someone with heart failure. So patients who have AFib are increased risk of stroke, but both from the AFib itself, but probably also have comorbidities that are going to increase their chances of developing a stroke. So when we're thinking about these patients, and we think about patients who have heart failure with a reduced ejection fraction, they can have and should have the same anticoagulation management, the same anticoagulation options as people who don't have heart failure, except I would say that these patients, all of them will have a CHA2 VASC of at least 1, if not more than that, and pretty much all of these patients should be on some anticoagulant. Now, warfarin is the one that we've used for years and years. We know all about the good and the bad of warfarin. This just here is one study that I use in a lot of my talks about AFib because I think it's very informative, looking at time and therapeutic range. So those people who have the highest rate of time and therapeutic range had the least chance of stroke. And that's what, when it says survival here, it's actually supposed to be stroke. So if you have a lot of time that you're appropriately anticoagulated with warfarin, great, your rate of stroke is going to be lower, or lowest. And as you have a lower time in your therapeutic range, you're more likely to have a stroke. And what you can see actually is that this bar right here is people who weren't on warfarin at all. These people, by the way, all had a CHA2 score of 2 or higher. So people who had no warfarin, they actually did better than if you had a very poor time in the therapeutic range. And whether, again, that's due to issues of that they were over anticoagulated and had hemorrhagic stroke, or whether that's due to people who can't keep their time in the therapeutic range have strokes for other reasons, we can't tease that out based on this data. But really, if you're going to have someone on warfarin, you want to make sure that they have a very good time in the therapeutic range. Otherwise, then we're looking at the novel anticoagulants, so dabigatran, apixaban, edoxaban, or rivaroxaban. All of them seem to be effective in those who have heart failure with a reduced ejection fraction. Just remember, with all of those, you need to know what their creatinine clearance is, and with some of them, you need to know their body weight, or their not their creatinine clearance, but their actual creatinine itself. Trying to figure out what the appropriate dosing is for these patients. Watchman, and I think our case is going to mention this a little bit, Watchman does seem to be an option in those who have a reduced ejection fraction. And then there's Lariat also, which you may or may not have heard of. Lariat is essentially a lasso that goes around the left atrial appendage. It is FDA approved, but not FDA approved specifically for this purpose, to try and close off the left atrial appendage. In the studies that have come out so far, there's about a 5% chance that you need open cardiac surgery with the Lariat, so it's not something that's done hugely often. And one of the things when we think about AFib and those who have a reduced ejection fraction, heart failure with a reduced ejection fraction, one of the keys really is, well, what's the issue for patients? Is it the fact that patients who have reduced ejection fraction get episodes of atrial fibrillation, or is it that the atrial fibrillation is leading to worse ejection fraction? And, you know, it's a chicken and egg thing sometimes. It's difficult to try and sort it out. What we know is that people who have AFib and have reduced ejection fraction, you have issues of rapid heart rates, and they don't seem to do well with that. Something specific about the irregular ventricular rate. So not just the rapidity of the rate, but the irregularity might lead to a decompensation. And then that loss of atrial kick in the setting of atrial fibrillation may lead to a decompensation. We know that patients who have atrial fibrillation with a reduced ejection fraction have an increased mortality compared to those who don't have AFib, have an increased embolic risk, like we were discussing, have a reduction in their exercise capacity and their MVO2, excuse me, the VO2 max is what that's supposed to say. And that we know that those who have worsening heart failure, and as your New York Heart Association class worsens, you're more and more at risk of developing atrial fibrillation. Some of the data is showing that as you get up to advanced heart failure, so those who have New York Heart Association class 4, you have up to a 50% chance of developing atrial fibrillation. When we think about the medications that are safe to use in those with reduced heart failure with reduced ejection fraction, so the safe meds, beta blockers, they should be on beta blockers anyway. We know that there's benefit, but this is a safe medication to use. Amiodarone. When I say safe medication, I'm not talking about some of the issues like pulmonary fibrosis or thyroid dysfunction. We're really talking about mortality here. So amiodarone has no effect on mortality in those who have reduced ejection fraction. Dofetilide or Ticacin has no effect on mortality. It does seem to show a reduced risk of heart failure hospitalization based on one study. Dofetilide is not a medication that we tend to use a lot. One of the main issues is cost, frankly. It's not a generic. So there is an increased cost associated with it. And then there are the issues of torsade de pointe and QT prolongation that you have to worry about with dofetilide. Also renal dosing you have to watch out for, or the renal issues. Sotalol, it depends on what their level of heart failure status is and ejection fraction. So if their ejection fraction is above 40%, I typically don't have any concerns about using sotalol. If it's below 40%, it's not my first choice, but it may be something that I use, especially in someone who already has a defibrillator in place. The concern is both the worsening beta blocker effect of it, so precipitating worse heart failure, and then the risk of torsade with these patients. But sotalol is sort of a second-line agent that you might consider using. Digoxin, there's, of course, a whole debate about digoxin in the setting of atrial fibrillation, but I think digoxin is a reasonable agent to use for these people as long as you're targeting a lower digoxin level for these patients. We know that dronedarone is an unsafe medication to use in those who have heart failure. So anyone with New York Heart Association class 2 or higher, 2, 3, 4, we know it's an unsafe drug to use. It precipitates worsening heart failure and heart failure decompensation. Quinidine is an unsafe drug to use also. Flecainide, propafenone, worried about the risk of polymorphic VT with these medications. And then, as you guys all know, with heart failure, we don't use calcium channel blockers in this population also because of the concern about decompensation. So in general, I tend to use beta blockers and amiodarone as my agents that I most frequently use for medication options. There's the AFCHF trial, which is probably about 8 years old now at this point. And this looked at those who were asymptomatic, who had heart failure and had atrial fibrillation, and they looked at a rhythm versus rate control strategy. So about 1,300 patients followed for 3 years. All of them had to have an EF of less than 35% with either class 2 to 4 heart failure, or if you're a New York Heart Association class 1, you could have an EF of 25%. Either paroxysmal or persistent AFib, but you couldn't have been in AFib continuously for over 1 year. Excluded those who they thought were going to get a transplant or those who were on hemodialysis. For the rhythm control strategy, it was amiodarone first choice, dofetilide or sotalol would be second choice. They encouraged cardioversions to try and keep people in the normal rhythm. Ablations could be done in this study. And for the rate control group, it was beta blockers or DIG with a goal of heart rate of less than 80 at rest or 110 on a 6-minute walk. And everybody was on anticoagulation or recommended for anticoagulation. And if you guys can see this slide may be a little small. There was no difference in the asymptomatic patients for death from any cause, no difference in the rate of stroke, no difference in the rate of worsening heart failure, no difference in the rate of composite outcome. So for patients who are asymptomatic, who have rate control, for these patients, I tend to just do a rate control strategy for them, and I don't think for the asymptomatic patient necessarily that there is this any improvement being seen in these patients. For the symptomatic patients, it might be a little bit different. For the symptomatic patients, so this was just one study that used peak VO2 as an endpoint. So they looked at essentially ablation versus rate control in this group, and those who got an ablation had an improvement in their peak VO2. They had an improvement in their Minnesota Living with Heart Failure score, and had an improvement in their BNP. So all surrogate measures, but it seems like if you do have someone who's symptomatic, that an ablation strategy would be better compared to a rate control strategy. Another study came out recently, a relatively large size for this type of study, about 200 patients. And what they looked at was doing an ablation versus doing amiodarone. So again, amiodarone being the main medication that we would use. And what they showed, similar to what you see in a non-heart failure population, was that ablation did have a improvement compared to amiodarone in your ability to keep someone in normal sinus rhythm. So in this group who, I think the predominance, I'd have to go back and look, but I think the predominance were paroxysmal, they had a pretty good success rate of ablation compared to amiodarone in keeping people in normal sinus rhythm. There was a meta-analysis from a couple years ago that looked at the ablation success rate in those with heart failure with reduced ejection fraction. And what they showed was that the overall single procedure efficacy for this was 40%. Not that great. Repeat procedures, so about 30% of patients, 32% of patients got a repeat procedure, and the success rate was up to about 60%, which sort of matches that other study that we saw. And you know, it's got a decent success rate. It's not great, but it's got a decent success rate. And what they showed was that you can get an improvement in ejection fraction and a decrease in the pro-BNP. Now, what you can see here is that at baseline, you're looking at people who had ejection fractions of 40%. So these aren't people who had EFs of 20 to 30% on average. It's sort of more in the level of the moderate LV dysfunction group. But there's a fair number of people that may have this moderate LV dysfunction that you can improve with an ablation strategy to get them back in the normal rhythm, getting into this chicken and egg thing. When you look at the major complication rate, it's somewhere in the 3.5% to 5% range, which matches what you see in non-heart failure patients, but a 1% rate of stroke and about a 1% rate of tamponade in this group. So overall, if I have a patient who has AFib and has heart failure with a reduced ejection fraction, so the first thing I'm thinking about is just the first question is, how are they doing at that moment in time? Is this someone you're seeing in the emergency room or on the floor? Are they hypotensive? Are they having significant shortness of breath? Are they having mental status changes, chest pain, whatever it is? It's just someone that you need to cardiovert urgently or emergently, or is this someone you can try and medically manage? So that's the first thing you need to think about. Number two would be the thromboembolic risk. So with this, essentially we anticoagulate everyone, whether that's with warfarin or one of the novel anticoagulants. I prefer the novel anticoagulants, but for whatever reason, cost or some other reason, you need to do warfarin, renal dysfunction, then that's appropriate to do. Because I'm an electrophysiologist, I'm going to think about what's the risk of inappropriate shocks if they have an ICD in place. So do I need to reprogram their ICD for some reason, make their rate go higher, like a rate of 200, let's say, before they would get shocked? Do I need to extend their time to detection? Do I need to worry about AFib discriminators? But these are some of the things I'll be thinking about. And then if it's their first time that they've had AFib, even if someone is asymptomatic, I tend to offer them a cardioversion, because a lot of people, you'll cardiovert them and they'll say, you know what, actually, I think I was symptomatic and I do feel better now in normal sinus rhythm. So I tend to offer this at least the first opportunity to assess, would it be beneficial to try and do a rhythm control strategy for these people in the long run? If then they go back into AFib, question is, do you have rate control achieved? Rate control being a heart rate less than 80 and then less than 110 with exertion. And if so, are they still having symptoms or not? And if they're having symptoms, then I'll pursue a rhythm control strategy, typically with amiodarone being my first choice. But if they don't want to take amiodarone, if there's some contraindication to amiodarone, if they failed amiodarone, then typically I'm offering ablation versus dofetilide as my second choice option. Okay.
Great. We'll let you do this.
Okay, so so the questions this time, which you guys actually seem to do pretty well on the first time, I think, but at least for this one, 100% of you said an answer. So let's ask again. Strokes in patients with atrial fibrillation only happen during AFib episodes.
I'm getting about 4 responses.
Okay.
There.
Yeah, so we'll wait for Maybe one more person to respond. Okay. So let's see. All right, so 100% of you got it the first time, 100% got it the second time. Great. So I think, again, that's one of the keys, is that we want to anticoagulate these people all the time and not just during the AFib episode. Great. Question 2. So which drug should not be used in those with atrial fibrillation with the New York Heart Association Class 2 heart failure with reduced EF? Just wait another couple seconds here for the other 2 people. Okay, we'll leave it at that. All right, so good, everyone got that. So dronedarone should clearly not be used in these patients. Amiodarone and dofetilide would be the first choices. Sotalol is can be used, but you should do it cautiously. And 3, it's rhythm control is better than rate control. I'm gonna preface this, I should say rhythm control is better than rate control in asymptomatic AFib patients. Should have added that word in. So in asymptomatic patients, is it true or false? Okay, 5 responses, great. Good, yeah, so in the asymptomatic patients, I would say it's false, that they seem to be equivalent. But in the symptomatic patient, rhythm control strategy might be a little bit better based on surrogate endpoints.
Great. All right. Thanks, Jordan. That was an excellent overview. We'll start with some questions, and maybe I'll just start based on this last question, actually, and on this notion around like symptomatic or asymptomatic heart failure patients. I mean, what is an asymptomatic heart failure patient versus a symptomatic heart failure patient, either in the research or in your own practice?
Yeah, so if you have, let's say, New York Heart Association Class 2 or 3, or someone who's got symptoms, who has AFib, I think it's difficult to assess, to tease out what the AFib, or how much is AFib versus their cardiac dysfunction. Yeah. And so for someone like that, I think the benefit of a cardioversion, even if they only stay in AFib, or excuse me, in the normal rhythm for a day or 2, you might get that time to try and make that assessment. You know, whether their symptoms are due to if it's shortness of breath, if it's lightheadedness or hypotension, or you know, chest discomfort would be unusual. I'm really thinking about those symptoms, exercise capacity versus palpitations, let's say.
Okay, great. Any questions from our audience?
I have a question.
Yeah.
This is Susan. In the study that you quoted that no warfarin is better than poor time in therapeutic range, in that study, what did they use as the threshold to define poor?
So they were doing it based on those deciles. So so they actually, if you go and look at the study itself, they break out CHADS 1 and CHADS 2 or higher. So CHADS 1, and but this again was just the CHADS 2 or higher. And if you had a time in the therapeutic range of less than 40%, then you were considered poor and your outcomes were worse.
Okay, that's great. Thank you.
So that study, just FYI, was about 6,000 patients out of the UK, registry data.
Okay.
And Jordan, if I was paying really close attention, I think I might have heard you say you would anticoagulate all patients with heart failure. I mean, that's not quite sort of what like CHADS 2 VASC or something would have you do, but
right.
So I misunderstood.
No. So I personally think that all patients with CHADS 2 VASC of 1 should be anticoagulated. Okay. If you look at the US guidelines, they say you can either do aspirin or you can do anticoagulation. If you look at the European or Canadian guidelines, they say everyone with a CHADS 2 VASC of 1 should be anticoagulated. Mm-hmm. I don't personally think that there's a role for aspirin anymore in the setting of AFib for anyone. Mm-hmm. And so my CHADS 2 VASC of 0, I don't use anything, but anyone with heart failure is going to have a CHADS 2 VASC of 1, and I think all of those patients should be anticoagulated.
Excellent.